Good morning, good afternoon, or good evening, everyone, depending on where you are in the world. Welcome to our second day of the AfriHealth Symposium. Yesterday was quite exciting, and we hope that today will be even better. We had our annual general meeting this morning, which was very well attended. And for those members that missed, we hope that next year you'll be able to join. My name is Elsie Kiguli-Malwadde. I'm the Director and Development at the African Center for Global Health, a renowned scholar and professor of family medicine at Stellenbosch University, and she's our immediate past president for AfriHealth. I would like to recognize the tech moderators, Sylvan Kaboha, Roger Lawrence, and Edward Onen, who are in the background making sure that our session runs well. Thank you so much. We would like to thank our speakers and would also like to thank you all for attending this first ever virtual conference for AfriHealth. It's a privilege for me to moderate at this panel of people that I know well, who are my mentors and colleagues, and with whom we share a passion for health professions education. So I'm really excited. If you look down at your screen, there's a Q&A box. That's where you'll be putting your questions, and some answers will be posted there. So if you have questions, please put them in the Q&A box. The chat box is for networking and comments. So you can use that for just comments and thank yous, and it has been quite active in all the past sessions. So we are going to start with our first speaker. Our first speaker is Professor Susan van Schalkwyk. She's a professor in health professions education and the director of Center for Health Professions Education in the Faculty of Medicine and Health Sciences at Stellenbosch University. Apart from her supervision of doctoral and master's students, she has more than 15 years experience in academic staff development. Her research interests cover a range of topics related to learning and teaching in the health professions, with a specific focus on strengthening postgraduate studies and academic writing. Much of her work is informed by the principles of transformative learning theory, with current projects intentionally looking to adopt a social justice agenda. Susan, you are very welcome, and now you have the virtual floor. Please go on and make your presentation. Thank you.
There we go. Elsie, can you just confirm that you can see my slides?
Yes, okay. And I can hear you very well. Thank you, Susan.
Wonderful. So good afternoon, colleagues, or good morning, as Elsie said, or good evening, and thank you, Elsie. It's wonderful to be here. I hope that you have been engaging in a stimulating symposium so far, in spite of the strange times in which we find ourselves. And thank you very much for the invitation. It gives me great pleasure to join you all, and I feel as if I'm back with old friends. It feels like the wonderful days of MEPI all those many years ago. I really wish we could be meeting in person, as I'm sure many of you do as well. It would be wonderful to renew old friendships and even build new ones. Nevertheless, here we are, and I've been asked to focus in these 15 minutes on health professions education in Africa. So that's where we're going to go. But before we start, I think it's important to share some context. So in 2009, Vanessa Birch, when she introduced African Journal of Health Professions Education, described the status of healthcare being in a desperate situation in Africa, and argued that one response, and she spoke to many responses, but one specifically would be to facilitate the emergence of a high cadre of high quality educators for the continent. And it was into that space that she and her editorial team envisaged a journal that would provide exposure for scholarship being produced in Africa. Scholarship that would address our unique challenges, our unique context, and offer opportunities for both experienced and emerging educators to contribute to building the body of knowledge or the body of literature in health professions education. Now, just 2 years later, Grayson and colleagues, and those colleagues included people such as Marion Jacobs, Nelson Sewankambo, who many of us are familiar with, and Fitzhugh Mullen, who so sadly passed away at the end of 2019. And together they conducted a review of medical education in sub-Saharan Africa. And their work confirmed some of Vanessa Birch's statements from 2 years earlier. They went on to emphasize the underrepresentativity of sub-Saharan Africa in the global literature on medical education. And here, colleagues, I'd just like to emphasize that I use the term medical education because that was what was being used at the time in those publications. But I myself really ascribe to health professions education. And they spoke about this underrepresentativity, and that the literature that was there was skewed towards just a few countries. In the years after 2011, and when we saw the rise of MEPI and similar projects across sub-Saharan Africa especially, we were fortunate to be able to start building on what was already in an embryonic phase. And we saw quite a growth in health professions education literature coming forth. And in fact, in 2017, I wrote an editorial for AJHPE in which I explored the notion of scholarship for Africa, which by then was AJHPE's tagline. And I reflected on the extent to which there was much evidence of growth in the area, but still asked the question whether we are taking this idea seriously enough, and called for critical reflection as to the extent to which our work is influencing our practice and our thinking, and possibly even the practice and thinking elsewhere in the world. Today in 2021, this evidence of growth is still there and it is increasing. But colleagues, there is still work to be done. So let's first have a look at this issue of research before we start looking at the task at hand. So research is, along with all the other roles of the academic, teaching, community engagement, and even administration, central to our academic endeavor. So those of you who are on this webinar today and who identify in some way or another as a medical educator or someone responsible for the clinical teaching of health profession students, we need to recognize this broader role. Research activity provides the vehicle through which we can explore and respond to critical questions with a view to building that body of knowledge and taking science forward. It is what we expect of our postgraduate students, for example, and it is the currency in which academia trades. So Khan and colleagues have described research as comprising work to extend the boundaries of what is known or possible. It represents a form of activity that is inherently challenging. And the second quote on the slide comes from the University of Sydney, where it expands on what the intention is and the way in which such work can be done. So not only the creation of new knowledge, but also the use of existing knowledge in new and creative ways. I don't want to spend a lot of time here, but I do want to draw your attention to the notion of this work being challenging and the importance of creativity that's sort of all mixed in there. But what about scholarship? Where does the idea of scholarship fit in with the idea of research? So in 1993, quite an old piece of work, Ruth Newman described scholarship as an activity that expands the entire endeavor of academic work, that occurs preliminary to and simultaneously with research. So immediately we realize that research in and of itself is insufficient if there isn't a scholarly framing that is thinking towards the research and afterwards building it out, the knowledge translation that we often hear our colleagues talk about. So she defined scholarship as an activity that expands this endeavor, that occurs preliminary and to, and that extends into the many roles of academic work, a quality or a mode of working, almost a way of being. So if research provides the depth to academic inquiry, then scholarship provides the element of breadth. For anyone wishing to be regarded as a scholar in a particular field, conducting research and disseminating it along appropriate channels is an uncontested imperative. So just briefly, what does scholarship look like? Well, we could look at many resources for this. Glassex's criteria are very well known. Work that has clear goals expressly stated, that has identified important questions, that is feasible, novel, ethical, relevant. But this set of criteria from Diamond I find particularly useful and reminds us that if we want to embark on this important work of ensuring health professions education research in Africa, we need to bring to the party a set of attributes. We have to bring our discipline-related expertise, and that by implication requires an awareness and understanding of what is out there in terms of health professions education. We need to be scholarly in our approach, what I was just referring to. Work with reflective critique, addressing the significance of the work, the process of inquiry, and what was learned. So there are aspects that we need to tease out in this work. It's not just about doing the empirical data collection and then reporting on it. There is a layer of depth of engagement that is also required. It has to have significance beyond the individual context. And we often struggle with this idea. I've done my research here in a small rural town in Africa. Yes, that was your site. That's your incubator. That was your laboratory. But how do I take that out and try to unpick and understand what that means beyond the individual context? Because that's when I contribute to growing the body of knowledge. It breaks new ground. It makes us think differently, see things differently, can be replicated. And the most important, that it can be reviewed and judged as meritorious and significant by our peers. So it's quite a tall order. But what does that mean for health professions education research? At the risk of stating the obvious, we need to really focus on us and our context now. Smith and colleagues have argued that health professions educators are tasked with engaging with what they have called educational scholarship. And in ways that will help future colleagues and future health professionals to develop to their full potential. Through the years, however, and as I alluded to at the start, health professions education research has endured much critique, with voices often calling for work that is more critically reflective. So the criteria that I've just been referring to. In his oft-cited article of 2010, Glenn Rager, and the article was called "It's Not Rocket Scientist," he called for reorienting education research from its alignment with an imperative of proof to one with an imperative of understanding, trying to see what sits behind the numbers, for example. From an imperative simplicity, where everything is carefully structured and organized and factored, to an imperative of complexity. And then eventually that would help us to move towards the generation of rich understandings of the complex environments in which our collective problems are uniquely embedded. And there are lots of important words there for our context, because what are the complex problems that are uniquely embedded in our context today, and indeed here in sub-Saharan Africa? So building on this notion of why is it important for health professions education, or why is it important for us and health professions education, particularly in the context of this AfriHealth Symposium? D'Souza Santos reminds us that since scientific knowledge is not distributed in a socially equitable way, its interventions in the real world tend to serve the social groups having more access to such knowledge. So we need to think about the knowledge that is being created and whether it is the appropriate knowledge and who is getting access to it. We need to think very consciously about our academic identity and our focus in our own work. Many of you might be familiar with this slide, which which comes from work conducted by a colleague of mine from Portugal, Manuel Costa, who in 2017 did an analysis of the 5 leading health professions education journals. Now, yes, this is skewed, and it was the 5 top health professions education journal in the world, but nevertheless, what we see here is that 5 countries in the world publish 3/4 of the papers that are being, or published 3/4 of the papers in these top journals. So if we ask questions about whose knowledge is being disseminated, and then add to that who's getting access to it, then we start realizing that we need to ask questions about whose agenda. The focus of this symposium is on Africa and the work that we do here. Clearly, decisions about what will be the focus of your research and my research should be informed by a range of factors that have relevance to our specific context. You might have something that's bugging you, that's keeping you awake at night, a stone in your shoe, but does that warrant investigation? What does your reading of the literature tell you? Are you up to date with the international trends and then know what might be important for your country, for our region, and for our continent? In 2019, under the auspices of AfriHealth, the Health Professions Education Research SIG, and a group of us conducted a modified Delphi. In our first round, we had 90 respondents, and we wanted to know from our respondents what they believe priorities for health professions education research in sub-Saharan Africa might be. Of the 90 who responded, 71 were health professionals, with that same number identifying as either somewhat experienced or very experienced in the field. Of that group, however, only 25 indicated that they had more than 5 health professions education related publications, with more than 33 indicating that they had not published in the field at all. Now, while I have no doubt that our respondents were very well published in their discipline fields, we need to think about what this means for health professions education. If the people who are teaching our students are not engaging with the scholarship that informs the teaching practice. From this work, it is clear that our respondents believe that creating an environment that is enabling for research was a key priority. And on the slide, you can see just 3 groupings that comes from that article: the enabling environment that I've just referred to, the enhanced student learning and focuses there, and strategies to improve pedagogical practice. And maybe just to highlight 2 issues on this particular slide, that the first bullet, addressing human resources for health challenges, was by far and away the strongest, most identified priority among our respondents. There was a sense that before we can really start thinking about research on the ground, we need to be thinking about ways in which we can address human resources for health challenges. And so we see the tension that exists in trying to respond to the research priorities that we do have. And I'd like to just add a second thing, as I mentioned. If I take you back to the Grayson article that I start with, many of these priorities were listed already in that 2011 piece of work. So we can talk a lot about where these priorities take us as a community. But again, as I said earlier, the message is clear. There definitely is work to be done. So what would an enabling environment look like? And as I come to my last few slides, in 2018, Rola Ajawi and her colleagues conducted a realist synthesis, and they suggested that an enabling environment focused on having a research strategy, the right people, the necessary income, facilities, and infrastructure. No surprise there, it came out of our Delphi too. And they emphasized the importance of collaboration. And I think the notion of collaboration is really important in the context of AfriHealth. It means that we can respond to the call that the forms of research being pursued in the 21st century will increasingly necessitate collaborative approaches. And I believe that if we are to grow scholarship in the Southern African region, then collaborative projects holds one of the keys to success. Having said that, it is complex, as Brew and colleagues have told us. It requires that we align our interests and our collectively extend our agency towards that common purpose. And that might mean that we have to give up our own individual darlings. We will need to attend to the structure and culture of our working groups and think about what can work for the larger community of practice as experts engage alongside non-experts. And we might have to transcend boundaries, do the boundary work that Etienne Wenger spoke about many years ago. So in that realist review that I referred to a moment ago, they identified 3 key cross-cutting mechanisms over those issues that I've just listed: time, researcher identity, and relationships. Time is something that resonates with all of us. Time is not only needed to get the work done, but it is more complex than simply the hours in a day. We need time to think, to do the sort of slow scholarship, not slow in terms of duration or pace, but in terms of emphasizing what matters and what is meaningful, rather than what is economically expedient and efficient. And just as an aside, Ajawi and their colleagues found that having protected time did not necessarily lead to better research activity, but it was about how that time was utilized and prioritized. So in closing, what are we going to do with our completed research? What are we going to do with our still being conceived research? What are we going to do with the stones in our shoes? What are we going to do with the research priorities that we have for Africa? Do we take pride in what we're doing? Or do we second guess ourselves because we're scared that our work will not stand up to public scrutiny, whether locally, regionally, or internationally? We cannot do this, colleagues. This renders us silent and takes away the possibility of us having something worth saying, of shifting the graph that I showed you earlier. So I close with this quote from our Delphi study, and I acknowledge my colleagues who were part of that study, Elsie Kiguli-Malwadde, Jehan Burdick, Michael Reed, and Marietjie de Villiers. Our study was premised on the fact that premised on the assumption that having a shared agenda could build evidence that is regionally relevant while facilitating the efficient and appropriate allocation of resources. Nested within this assumption is an acknowledgement that those of us who live and work in this region are best positioned to chart a way forward and to resist hegemonic practices that are often externally imposed. Colleagues, this is our priority, and it is also where a myriad of possibilities lie. Thank you.
Thank you very much, Susan, for that insightful talk. It really speaks to our heart in the region, and thank you for all of us in the region. Thank you very much. So I'll hand over to my co-moderator, Marietjie, to invite our second presenter. The Q&A, please don't forget to put your questions in the Q&A box. Over to you, Marietjie.
Hello, just waiting for Susan to stop sharing.
Susan, could you please stop sharing?
It's not letting me unshare. There we go.
There it goes. Okay, there we go. Okay, thank you very much, Susan. A great call to action for us health professions, educationalists in Africa. So now it is really my privilege to introduce you to Professor Sarah Kiguli from Makerere University in Kampala, Uganda. Sarah is a professor in pediatrics and child health, and she's a previous head of the department at Makerere University in Uganda, Kampala. She's the current principal investigator of the HEPI project in Uganda, which is a follow-up on the MEPI project. She has had tremendous impact on the development of health professions education as a discipline in Africa and particularly in East Africa. And as such, she is the founding chair of the East African Association for Health Professions Education. She also has done international work with international reach, and she is a global faculty advisor of FAMER, which many of you will be familiar with. So, Professor Kiguli, we are really privileged to have you here as a pediatrician and a health professions educationalist, or shall I say a health professions educationalist first. And we're really looking forward to your talk. Thank you so much.
Thank you very much for that kind introduction. And good morning, good evening, and good afternoon, everyone. I would like to thank the organizers of this symposium for inviting me to share my experience and to give a presentation. And I think your question, am I a pediatrician or a health professions educator? I think I'm both, but since health professions education for a long time has not been recognized as an entity, then we remain behind what is recognized, and this could contribute to what our previous speaker was talking about. So the title of my presentation is before you, and I'll go trying to move my screen. It's refusing again. IT, can I be helped?
Sarah, do they have your presentation and they can see?
They do have it, but I don't know what.
So then you need to unshare. You can unshare, yeah, you've unshared. So Roger Bernard, can one of you confirm that you have the presentation to share? Yeah, it's coming up. There we go. Okay, so Sarah, you'll just tell him when to move. Okay, just there we go. Okay, all right, thank you.
Okay, so that's the outline. And as I present, I'll share the experiences I have had at Makerere University College of Health Sciences. It's refusing to move again. Okay, so I'll start by asking ourselves, what is a curriculum? And I know that this word curriculum has different meanings and it's not very well understood by many of us who are educators or who teach. Some of us refer to it as a syllabus, the content, the learning strategies, but a curriculum is much more than that because it defines or it is about what everything that should happen in a training program, including the learning outcomes, the content, the experiences, assessment, the educational environment, and everything else. Next slide, please. So why is it important to have a curriculum? To guide systematic implementation of the learning activities. It guides faculty, it guides students, and it's a tool to help educators achieve intended learning outcomes. And most especially, it's something to help us address priority needs in our communities or where we train from. Next slide, please. So who should be involved in developing or building a curriculum? Stakeholders who include faculty, representatives of the community, other partners, and health professions educators, in bracket, people who have been trained and who have an idea about the process of health professionals education and how people learn. Many times we come as experts and we start developing curricula without knowing what should happen. Students should be part of it, as well as graduates, if this curriculum or this training has been there before. So everyone should be involved. Many times it's only the educators that are there. So I'll go through building the curriculum, the steps. Next slide, please. And these steps have been got through literature. They're there. Identifying the need of a curriculum or the program is very important. So the questions to ask, why is the program needed? What problems would it address? And we need to look at the society or the population, the disease burden, the health workers there, their numbers, their skills, and also, do they have gaps in their competencies? The problem could be in the current training programs where key competencies are not addressed, where some of the content areas are also not addressed, but also it could be the learning methods that need to be improved. So looking at the problem helps us to build a curriculum that is relevant, but also to address social accountability so that we're relevant to the needs of the population. Next slide, please. So the second step, maybe before the second step, the conduct of the needs assessment should be in consultation with the stakeholders. And we need to understand the tasks that health professionals perform in order to identify the key competencies, things that they should be able to perform. And we use this in developing the curriculum. We need to study what errors or what gaps they have so that we correct them in the curriculum. Sometimes wise men or women sit in offices and write a curriculum without thinking about this. And this is something that we should not encourage. So the needs assessment helps to identify the expected outcomes, the content, and everything in the curriculum. Next slide, please. This is just to say that the population needs, okay, should guide what is in the education program so that the people we produce are able to change or to work in the health system and transform it, okay? And we also need political support when we are building a curriculum. And that's what we call transformative education that has been talked about by the previous speaker. Next slide, please. So I'll talk about briefly the Makerere experience. We had a major reform in our medical education curriculum. Actually, it was in all the curricula at the Faculty of Medicine, then nursing, dentistry, pharmacy. And this has been put in the literature. So we went through a needs assessment to find out what the gaps of our students were. We engaged stakeholders, and the next slide will give us what we found, which helped us to design the curriculum then that started in 2003. This publication was after we had done it. Next slide, please. So the needs assessment told us that our graduates had some gaps in problem-solving skills, leadership skills, communication, those skills that are listed up. So the change in 2001 addressed these gaps. And we also adopted a new model in order to address the gaps that we had found. So it is possible to do this, and this has been done at the African continent. It was a 2-year process, and we actually learned from colleagues in the region. Next slide, please. So the second step is, after the needs have been identified, establishing the expected learning outcomes. And this is the key for a competence-based or outcome-based education, where the learning outcomes are key drivers to the curriculum development. We focus on what graduates should be able to do, not what they know. And we are obsessed with what they know as teachers. So this helps us to decide what they should be able to do, to decide on the competencies, and these learning outcomes then guide the development of the other areas of the curriculum. And these are things that they should be able to perform. And there I have an example. It could be a physical examination, it could be working in collaborative groups, and there could be many others. So the next step, next slide. So this one is from the Lancet report of, I think, 2010, just telling us that competence-driven curriculum is where we are, and it has been, we have come to this from a long way, over 100 years, but many times we are at the first science-based curriculum, where we focus on what should they learn. They should have anatomy, they should learn physiology, they should learn this, instead of asking what should they be able to do. Next slide, please. Still the experience at Makerere. So in 2008, we then looked at our situation. We had a review in 2003. So we again looked to see where we were after 8 years of implementing the curriculum of 2003. And we have published that situational analysis of teaching and learning of nursing and medicine students at Makerere University. And the next slide tells us what we found at that time. Next slide, please. So yes, that the core competencies that students were expected to achieve were outlined, and the content was locally relevant in line with our health sector strategic plan. The learning experiences were also relevant, but there was a need to have better assessment and also a need to develop a competence-based program to help us better deliver our curriculum. So in 2010, we developed a curriculum that was competence-based according to our understanding to improve on what we had done. So building a curriculum needs recurrent or ongoing assessment to see where we are and answer the question that are we really addressing the needs of our population. Next slide, please. I'll go through the other steps quite fast. Next slide, please. I've talked about there are also gaps still. So we adopted those domains, I think from the American Academy. So that those are what guided us. And we did this not only for Makerere, but for all medical schools in Uganda. The implementation might have had some hitches, but at least we tried to move beyond where we were. Next slide, please. So the third step after competencies have been identified, I have no time, is to agree on the content. Next slide, please. So the content, but also how the content should be put in the curriculum, organization of the content. Many times we first do the biomedical and then the clinical. And then when we do that, the students don't fully understand the meaning, why they should learn the biomedical sciences. And yet we need them to explain the clinical sciences. So vertical integration is very important. Next slide, please. So then we decide on the educational strategies, which should be many, based on the principles of adult learning, including student-centered learning, interprofessional education, and others. It should be aligned with the competencies. Next slide, please. Then we'll decide on the learning methods, which should also be many. I've picked out community-based training, small group learning, and in this era, online training or blended learning as key things, plus simulated-based learning, because we may not be able to do face-to-face now and maybe in the future, but also to improve what we do. Next slide, please. I'm about to finish. Then we prepare the assessment. Many methods should be used, and assessment should be in line with the competencies that we want our students to learn. And formative assessment is very important. Next slide, please. We need to communicate the curriculum to the students, to the faculty. Many times faculty don't know what is in the curriculum and they are teaching. And next slide, if we don't communicate as we are developing, after we have developed and afterwards, then students learn what they learn is actually different from what the curriculum is. So when we communicate, then what is taught is the same as what is learned or similar, and also what is learned. Next slide, please. Marietjie, tell me, put your hand up if you need me to stop. It's important to have an appropriate learning environment. Next slide, please. Okay, I will not go through that. And then to manage the curriculum, we need a system of coordination and management, and leadership is very important. And there should be a structure. Many times we've failed because we don't have this. Next slide, please. 2 minutes, then I'll finish. Success factors, leadership, coordination, faculty development, they are important among other things, because many times the faculty don't know what to do. We come as pediatricians and we may not understand how to train. Next slide, please. So in Africa, the disease pattern, the competences needed, the learning landscape, everything need to be actually we need to use that when we are building our curriculum. Next slide, please. And for interprofessional education, I was asked to comment, we need to plan together the different professions. We need to implement together. And there are opportunities for this in small group learning settings, in the community, in the clinics, and in the simulation-based learning areas. Next slide, please. The future e-learning and maybe additional competencies. Next slide, please. So in summary, the desirable competencies should guide curriculum building. We need to address population needs. We need to involve stakeholders, and there should be constructive alignment from competences to content to learning methods and assessment. Faculty development and leadership are key. Thank you very much.
Thank you so much, Professor Kiguli. It was very interesting and very informative for those that are developing or going to develop new curricula. I'm going to hand over to Professor Kiguli-Malwadde to introduce the next speaker.
Thank you very much, Marietjie. Thank you very much, Sarah, for taking us through that journey, very interesting journey, and for those observations of the important factors that we need to look at. It is my delight to invite Dr. William Burdick, who is an MD. He's the Vice Secretary General of the Network Towards Unity for Health. This is an organization of community-oriented health professional schools and many other organizations that are community-oriented. He was the former Vice President for Education at FEMA, where he was responsible for creation of global faculty development programs for health professions educators. He has received awards of excellence in teaching, including the Lindbergh Award and the Trustees Award in his capacity as Professor of Emergency Medicine at Drexel University College of Medicine. He's a graduate of Oberlin College, Cornell University College of Medicine, and University of Pennsylvania. He completed residence training in internal medicine and is certified by the American Board of Emergency Medicine and the American Board of Internal Medicine. I know that Bill is a passionate educator and also is passionate about faculty development, and he has contributed a lot to improvement of faculty globally. And for us in the region in Africa, he has mentored many of us in health professions education. Bill, you are welcome. The floor is yours.
Thanks very much. I'm going to start by sharing my screen. I know the time is limited, but thank you so much. And I approach this talk with the humility of an outsider, and I recognize that. So those comments, my comments need to be taken in that context. And it is wonderful to be among friends on the panel and among friends that I recognize in the audience. So I've been asked to talk about faculty development in the area of health professions education research. So I'm hoping that by the end of the next 10 minutes or so, that you'll be able to contextualize research within health professions education in Africa, delineate the relationship between research and evaluation, identify the core needs of faculty who want to do research, and locate or create resources to meet those needs. And I will say that Susan and Sarah have made my job much easier with their excellent presentations that have laid the groundwork. So why are we talking about research? Susan had a very erudite explanation of research. I'll give you the sort of the ground level view. We want to know what works in health professions education and, as Susan emphasized, why it works. So we're talking about evaluations of innovations and better understanding of existing methods. And that requires familiarity with what has been studied and in what context. What are the gaps? What are the weaknesses? What are the successes? And importantly, what's the context in which those successes occurred? About 15 years ago, I wrote about some of the challenges in health professions education, and unfortunately, some of them are still relevant. So I talked about physical infrastructure improvements that were needed, particularly in a stable electric supply and internet backbone, prioritization of access to scientific literature, and then interestingly, strengthening the internal data resources within universities to facilitate institutional self-review and evaluation. Now, people get hung up on this distinction between research and program evaluation, and there are many elaborate diagrams that can help you understand that. But here's my simple explanation. Program evaluation is for the stakeholders, the people that made the innovation, the people that are paying for the innovation, the people that are affected by the innovation, anyone who is directly has a stake in the innovation. Whereas research is for everyone, not just the stakeholders. And so it requires a couple of additional things. And those additional things are a blend. There's not a hard wall between evaluation and research. The key question for someone doing evaluation is, can the results be generalized? And can it achieve the 5 Ps? Now, Susan already mentioned the 5 Ps without calling it that, but I'll call it that because I like simple models. So this is the work that she referred to from Diamond. It has to have a product that has expert knowledge as its foundation. The process must be rigorous. Now, this applies to evaluation and research because in both cases, the key is making a credible case that the results that you find are not just due to chance, one, and two, the results that you find can apply to a broader audience, a broader group. And the ways to do that are twofold. One is to have random selection of participants so that you're less likely to have a coincidence or something that's predetermined as the outcome. And two, there needs to be a sampling methodology that convinces the readers that your results are generalizable to a larger universe, now whatever that universe may be. Now, certainly, as Susan mentioned, needs to be peer reviewed. It needs to be publicly available, something that research has to have, but evaluation does not, and likewise for peer review. And then importantly, it needs to be a platform that others can build on if it's going to be research, just as your research will be something that you're building upon, whether it's a theory or a concept that's been published, but that others can build on your work. So these are the things that are required for scholarship. A couple of them, expertise, rigorous, apply as well to evaluation. I'm a big believer in getting groups of people together to read the literature and critically review it. A journal club is a terrific way to do that. It allows participants to learn the current literature, understand the latest education methods that are being discussed, and the evidence for their effectiveness or the gaps in that evidence, understanding why they work, and taking that from the literature, again, seeing where there is a deficit in explanations, and then understanding the contexts in which they worked, because those contexts may be a useful platform to build upon to apply that work in your context. And that becomes new research when you take work that's been done in one context and apply it in another. If you don't read, you can't write. And I think this is probably the most important message in faculty development for research that I can offer. Reading the literature tells you not just what's out there, but how it is presented. And it helps you understand some of the methodologies. Now, there are plenty of tools for helping faculty develop research skills that are freely available online. All you have to do is search for research question identification or problem identification, and you will find algorithms that will guide you through creation of a problem statement. Similarly, for literature search, hypothesis generation, methodology, analysis, reporting. This is actually the easy stuff. The design stuff is the easy work. And what another resource that I just will mention, because I found it terrifically useful, is yes, this book was published about 60 years ago. However, it has had, I don't know, 45 editions since then. It happens to be free online at this point because it's been around so long. But for my simple brain, it's got diagrams and pictures. And so I really think this is a fabulous book. It's skinny, which is also another appealing piece of it. But a nice piece of work for helping people design their research so that there is more credibility and the reader of your research will be convinced that the results are not due to chance. Now, this is something, again, that Susan and Sarah indirectly alluded to, and some of the chats, Kate mentioned this in the chat. The work needs to be locally driven. And I say this not just because it will certainly help the community, but I think a lot of faculty do research because they are supposed to do research. They do research because the faculty promotion system requires them to, but they don't have the passion in their gut to do it. Identifying a local need can really move beyond that and help you get that passion. So talking to the community, talking to students, talking to faculty, administrators, health systems administrators, they can help you identify the current status and where the needs are and where there's a puzzlement about why something is working or is not working. And then I think developing some innovation as a nice way to drive your motivation. And then for faculty development purposes, it's very easy to create almost a hand-holding guidebook that moves people step by step through that. We did this when I was with FAMR. These are some of the categories that we have, but the important point is that it starts people off thinking about the why question. Why is this important? What are you going to do about it? How is it going to result in change? And then I'm a big believer in understanding how those outcomes are linked. We call that an outcomes chain or a theory of change. But that kind of a graphical representation of one outcome leading to another, almost in the sense of a set of hypotheses, if then, that becomes a very useful tool for evaluation and of understanding what your project is trying to achieve. It's not about the outputs. It's not about how many students or how many hours. It's about who and what will change. And then for each of those outcomes, there are indicators that can be addressed and data collection methods. The second part needs more intensive approach if it's going to be generalizable to rise to the level of a research project. So in summary, what I believe we need is some infrastructure issues like stable electrical internet access to the literature in order for faculty to develop in their research skills. The distinction between evaluation and research, I think we get hung up on that. Evaluation is for stakeholders, research is for everyone, and the sense of everyone is embedded in that is the concept of generalization to a larger universe. Both of them require rigor. There's no question about that. And I just want to make that clear. Journal Club facilitates understanding of current knowledge. A guided project development process may provide an application of evaluation and research methods, and then methods for problem identification, research design are all available. So thanks very much. I hope we have some time for questions. And I appreciate giving me this opportunity. Thank you.
Thank you very much, Bill, for that presentation, for the process you've taken us through with simple steps. I think that is very useful. Thank you very much. Now I'll hand over to Marietjie. Please, media. Okay, they've muted. Marietjie, I'll hand over to you to handle the questions, and you've been watching the clock. You know how much time we have left. Over to you, Marietjie.
You're on mute.
You are muted, Marietjie.
Sorry. Thank you very much to all the speakers. We have had 7 questions in the Q&A box, of which 6 have been answered. And I see Sarah is still typing an answer. Maybe I'll just look at the one that's not. Sorry, Professor Susan had to leave, unfortunately. So, Dr. Comfort Salim, maybe Sarah can answer this. Is interprofessional education realistic in Africa? If yes, please, how can we achieve it?
Yeah, a very interesting question. I think it is relevant. It is relevant, and I believe that we can achieve it if the different professions can come together. I think we can achieve it. There are worries that the doctors will not listen to the nurses. I saw it in the somewhere. But I think it is something that is relevant, because when we practice with the other professions. So I don't think that if we practice together, then we cannot learn together. And where I work, where I practice, the nurses are there, the students are there, the medical students are there, the nursing students are there, other students are there. So why can't we learn together? Why can't they learn together? Why don't we as faculty plan together and then teach together and then do things together, role model that? So I think it's feasible even in Africa. And we can give other roles to the nurses. By the way, we have already done that. They do a lot, including leadership. So I think it's feasible.
Elsie, is there time for one more?
Yes,
Elsie?
one more and then we close.
Okay, so this is one for Sarah as well. If during implementation of a curriculum challenges of constructive alignment arise, how best can it be dealt with? Especially if the curriculum is not due for review as yet.
Oh, I think a curriculum is a living document. And I don't think that the curriculum itself is very prescriptive, but the implementation plan is where you need all the details. I believe that you can correct some of the things if they're not gross and it's allowed. The important thing is to identify that there's a gap, and then together with everyone, including the leadership that I talked about, I think some things can be fixed. I'll give you one small example. No one knew that COVID was there, and it's addressing it. Learning is one of the things that we need to adopt now. And if we don't, then it will not train anyone. So I think it is possible if there's someone who is monitoring and also a process of evaluating which we don't have many times. So if there's a process of coordination, monitoring, evaluation, and there's a system of addressing such gaps, I think it can be done.
Okay, thank you very much. There's one or two more, but unfortunately we've run out of time. So I hand over to Elsie to close.
Thank you very much, Marietjie, my co-moderator. Thank you to the technical moderators. It's run well. Thank you very much. I'd like to thank our speakers, Bill, Sarah, and Susan who had to leave. Thank you so much for your time and for those beautiful, insightful presentations. Thank you for attending our conference. Everybody who is in attendance, we appreciate each one's contribution and for all those chats and questions. We will go for a break. Sorry, we've eaten into your break by 5 minutes. So there are going to be other sessions after this. Please come back in about maybe 30 minutes. It will be at 15 past 14. That is GMT. You are welcome to the rest of the conference. Thank you, everyone.
Thank you.
And have a good day.
Thank you.
Thanks, everyone.
Bye.
Thank you.
On nous jamais